Good morning to all. Today's topic of discussion is pre-anesthetic evaluation of COVID-19 patients. Now, what sort of patients do we see in our pre-anesthetic clinic? We have actually 4 categories. Patients who are right now COVID positive, but they are asymptomatic. Patients who are COVID positive, but they are symptomatic right now. Patients who are post-COVID, they have completely healed themselves and they're totally asymptomatic, and patients who are having long COVID syndrome or some sequelae of other because of the COVID affliction. Now, what sort of patients do we see in our pre-anesthetic clinic? We have actually 4 categories. Patients who are right now COVID positive, but they're asymptomatic. Patients who are COVID positive, but they are symptomatic right now. Patients who are post-COVID, they have completely healed themselves and they're totally asymptomatic, and patients who are having long COVID syndrome or some sequelae of other because of the COVID affliction. Now, this is the full spectrum of COVID in which the patient can meet us. Like, for example, he would have already contacted the disease, okay, and but he's not yet PCR positive, or he might come to a state where he is PCR positive and he may come for some emergency surgery, or maybe that he's no more positive and he's no more infective to doctors or other healthcare professionals, but he's having some affliction or the other, and at this point of time he may come for something like mucormycosis, FES for that, or something like tracheostomy when he's on ventilator, or in a post-COVID state where he has completely healed himself from the disease, but he's having some effect or the other, affecting one system or the other. So this is the full spectrum of disease in which a patient who's COVID positive can present to us. Now, as anesthetist, whatever we do to a normal patient, we're supposed to do for COVID patients also, right? So we do a thorough clinical examination, we do an airway examination, we check the vitals, we check the investigations, which are the investigations: CBC, RBS, RFT, LFT, ECG, chest X-ray, CRP, D-dimer, and as we proceed, there will be a lot more which is needed to do depending on the case-to-case basis. Now, this is about COVID surgical weak patients. This is an international cohort, okay, and around 80 countries are participating in it. And this prospective study, it aims to find out what is the optimal timing of surgery for SARS-CoV-2 infection, and also to determine that, what are the global key surgical indicators, right, to assess the key surgical indicators, for example, like post-operative mortality. Right, it is supported by one of the many countries and many international agencies, and it is actually conducted by National Institute for Health Research. Now, one of the major publication or paper which has presented by this group, collaborative, which came in the Lancet, okay, it says, about the age and the complications when they undergo surgery, right? Now here it has been found in this graphic, and very well see that patients who are more than 70 years of age, when they come for any surgery, whether it is emergency minor or elective major or emergency major, the mortality rate, the 30-day mortality rate is really very high when compared to patients who are less than 70 years of age. So at this point, we have to remember when we're doing a pre-anesthetic checkup, and naturally this we have to tell when we're taking consent, informed consent, right? So now coming to the pregnant patients. A critically ill parturient usually is very less. Why? Because the clinical course of COVID-19 appears to be mild in most of the pregnant patients. But there are case reports, and there are patients, although the incidence is less, they come with decreased LV ejection fraction. Maybe they have some arrhythmias or other. And, one report says that bradycardia was reported in 1/3 of the women who were admitted with COVID positive, and cardiomyopathy also can be seen, which we call either viral cardiomyopathy or stress cardiomyopathy or whatever. Right. So in such case, how do we proceed? We have to take a CT test, and cardio biomarkers also are needed before proceeding on, what type of surgery we have to do and how we have to proceed and all. Okay. Now, this COVID pandemic has started COVID specific clinics where the patients who are, affected with COVID, and after that in the post-COVID state, they are rehabilitated. And, this COVID clinics have worked really well in enrolling patients for research studies. Okay, so from such so many of such COVID clinics, many papers have come out, and one of this is the meta-analysis, which has involved almost 7 or 8 countries like Italy, United Kingdom, you can see there, right? And they have included all patients, that is patients who were having acute COVID features, patients who were in the post-COVID state. Everybody has been included. And what this paper tries to analyze, the meta-analysis tries to analyze, is what are the common symptoms which are seen in the post-COVID state. And as you can see here, they have divided it into general sequelae, where the patient will have fatigue, joint pain, muscular pain, like that, or something like a respiratory sequelae, where the patient will have dyspnea, cough, or cardiovascular, like chest pain and palpitations, anxiety, sleep disturbance, post-traumatic stress disorder, loss of taste, headache, and diarrhea. And definitely the quality of life is also reduced to a major extent in many patients who are afflicted with COVID syndrome, post-COVID syndrome. Okay, so now each and every system we will see in detail. If a post-COVID patient or a COVID patient is coming to us, how we will proceed. So as far as the respiratory system is concerned, the commonest symptom the patients have is dyspnea. So till now, a pulse oximeter was never there in the pre-anesthetic clinics, isn't it, till 1 or 2 years back? But now for every patient, we check the SpO2 when he comes for assessment. Now, as you all know, hypoxia is seen even in the post-COVID state. And if any patient is coming to us whose saturation is less, it is very important that we ask them to do a CT scan. And the typical finding which we get in the CT scan is a ground glass opacities, and which may be there even for months together after COVID infection. Or we may also get some fibrotic changes, which explains very well the reduced diffusion capacity and the resultant hypoxia. So how do we go ahead with this patient? How do we optimize the patient? We have to do pulse oximetry, serial pulse oximetry, 6-minute walk test to know how much is the cardiorespiratory reserve of the patient. To know the lung, reserve, we have to do the pulmonary function test, and of course, high resolution computed tomography and even pulmonary angiogram, depending on the case-to-case basis. Now, coming to the hematological complications, this is one study with one cohort which has been done in New York City Hospital, and it came quite early in 2020. And what they have found is the venous events, of admitted patients in this New York City health system was around 6.2%, and 3.2% of these patients were having pulmonary embolism, 3.9% were seen to have deep vein thrombosis, and as far as the arterial events were concerned, around 11.1% of these patients had arterial events, and out of which 1.6% was stroke, 8.9% was myocardial infarction, and 10% of patients had systemic embolism. Coming to the post-COVID state, papers show that the thromboembolic events in patients who have recovered themselves from COVID is around less than 5%. And these patients usually, depending on the D-dimer levels, are on anticoagulation. And some of these patients, because we don't know how much is or what is the duration of the hyperinflammatory state, these patients may be on continued oral anticoagulants because of the high D-dimer levels, especially patients who are like having cancer, immobility, or the imaging has confirmed venous thromboembolism. In such patients, the oral anticoagulants may be continued for even 90 days or more. Now, this is a very, very important slide, okay? Now here, the patients who are on oral anticoagulants have been divided depending on the surgery into three categories, that like patients who need immediate procedures, patients who need urgent procedures where we have some 1 or 2 hours of time to go ahead with surgery, and patients whom we can, expedite. We can just ask to come after some time, right? So those patients who need immediate procedures, of course, in all three categories, we have to send blood sample for full coagulation panel. But those patients who are needing immediate procedure and urgent procedure, it is better if we reverse the action of the oral anticoagulant if the blood sample is showing that some abnormality is there, like if there is any PT derangement or APTT derangement. It is better if we reverse them. Okay, see, before proceeding to surgery. But in those cases where we can just wait, like if it's an appendicitis and it's an acute inflammatory state, give antibiotics and see for some time if it's receding, and then go ahead with surgery. Okay, depending on case-to-case basis, I may be wrong in selecting this surgery, but this is how it is explained as. Okay, in such cases, just wait, see how the patient is responding. And then after that, repeat the coagulation panel, and then you can go ahead with surgery, right? Now, this is, again, a little bit in detail. We are going to see the 4 commonly used oral anticoagulants. These are the dabigatran, apixaban, edoxaban, and rivaroxaban. Now, here, what I want you all to see is the elimination half-life. Now, almost all these drugs have got very, very less elimination half-life, right? It is around 12 to 17 as when compared to warfarin. So this is around 12 hours, this is 10 to 14 hours, or rivaroxaban is just 5 to 9 hours. That means they're very easily eliminated from our system. And as you can see here, these 3 drugs, that is apixaban, edoxaban, and rivaroxaban, are factor Xa inhibitors. So almost all of them will have PT-APTT derangement, and dabigatran will have thrombin time derangement, while other 3 will not have any thrombin time derangement. Now, this is a very, very important informative slide. Okay, right now here, the patients who are receiving these drugs are divided again depending upon the surgeries where the bleeding risk has been explained. Previously, we saw whether the surgery is emergency, non-emergency, like that. But now here seeing depending on the bleeding risk. Okay, so now we'll see the surgeries where there is minor bleeding risk, like for example, incision of abscess or glaucoma or something like that, intervention, cataract, or endoscopy without biopsy and all. So in such patients, as you can see, we are continuing oral anticoagulants, even the previous day of surgery, even the night dose, the PM intake is given. There is no bridging. In the morning, we are omitting them, right? The morning dose of apixaban or dabi is omitted. And then the all these oral anticoagulants, whatever the patient is on, is restarted 6 hours post-operatively. And the night dose is very promptly given. Now, come to the next one, that is patients who are having low bleeding risk, that is surgeries which are having low bleeding risk. Now, which are these? Biopsies done, right? Endoscopy with the biopsy. In previous thing, biopsy is not included. Now, here we have prostate or bladder biopsy, then electrophysiological studies, ICD implantation, non-coronary angiography. So in all these conditions, the morning dose is given even the previous day of surgery, but we are omitting the night dose. Right, the night dose of dabi, apixaban, if the patient is on in edoxaban or rivaroxaban PM intake, that also is omitted. There is no bridging. The morning dose is omitted, and then the drugs are restarted again in the night, not after 6 hours. Okay, so this is something which we have to know. Now, coming to the surgeries, which are important to us. See, the previous 2 cases, the anesthetist, I don't think may be playing a major role, right? So it may be something like monitored anesthesia care. But here, if one has to see, spinal and epidural are considered as, interventions where there is high bleeding risk, okay? And we have complex endoscopies like ERCP, abdominal surgery, orthopedic surgery, liver biopsy, TURP, kidney biopsy. All these conditions are considered as conditions where there is high bleeding risk, okay? So in such patients, as you can see, 48 hours before the procedure, apixaban or all the drugs, okay, all the oral anticoagulants are stopped. There is no bridging here also. And here we have to definitely do the PTA, PTT, thrombin time, and factor Xa assay whenever it is possible or wherever it is possible. There is no bridging here. And on the day of surgery, we are not going to give the drugs. And even for the next 24, 48 to 72 hours, up to 72 hours, we are not going to start oral anticoagulants. Depending upon the hospital protocol, we may start thromboprophylaxis, but no anticoagulants up to at least 48 or 72 hours post-surgery. Right, now we'll go to the cardiovascular involvement. Now, what are the symptoms the patients may have? They may present with palpitations, and most importantly, it will be something like inappropriate sinus tachycardia or postural orthostatic tachycardia, or the patient may have dyspnea, and chest pain also is considered to be one of the common symptoms in the post-COVID afflicted patient. And it is mainly because of increased cardiometabolic demand, myocardial fibrosis, all these things, and some patients even have autonomic dysfunction. So in these patients, we have to do a thorough clinical examination. ECG is a must, and echo also is a must. And we have to know something more about this new entry into our anesthesia armamentarium, which is called as cardiac MRI. So here is one study which has been done in patients who were having cardiac injury and patients without cardiac injury. And it has been seen that the survival risk in patients who are having cardiac injury is much, much less when compared to patients who were not having cardiac injury when they were admitted in hospital with COVID-19. Okay. So this is about cardiac MRI, and in cardiac MRI, what is followed is something which is called as Lake-Louis criteria for myocardial inflammation. And as we all know, the virus causes myocarditis and myocardial inflammation, right? COVID-19 myocarditis, it is called. And the images which we usually see are the T1 images, T2 images, and then there is something which you have to know, something called as a late gadolinium enhancement. And these are the three common protocols which are followed whenever MRI is taken. And myocardial edema is found by T2 mapping, and LGE or late gadolinium enhancement shows ischemic injury, that is myocardial injury, which can be ischemic as well as non-ischemic, and COVID-19 causes non-ischemic myocardial injury. And there are supportive criteria also, that is pericarditis and also systolic LV dysfunction. These are supportive criteria, and the most important criteria which shows ongoing myocarditis is myocardial edema and non-ischemic type of myocardial injury. Now, this is one study where the myocardial inflammation and dysfunction in COVID-19 patients were studied, and it was assessed using cardiac MRI, and 18 COVID patients were enrolled for the study. And what we have to see is all 100% of them, okay, they had some problem or the other in echo or MRI, and they had high troponin T levels, okay, and some had minor LV dysfunction, and some had the what is called as a global longitudinal strain pattern, and 39% had edema as per the Lake-Louis criteria, and biopsy showed increased macrophages in all 5 samples. Now, the previous slide showed all those patients who were having high troponin levels. Now, in this paper, around 100 patients were selected, and 33% of them were hospital admission cases, and 77 were out of the hospital home quarantine types. And here you can see that only 5% had elevated troponin, and none of them had cardiovascular symptoms, and all of them were subjected to cardiac MRI. And what they found is 78% of these patients had abnormal cardiac MRI findings, low ejection fraction, 32% had gadolinium enhancement, which shows myocardial edema, and pericardial enhancement was also seen, right? Pericardial injury, pericardial edema, everything was seen. Now, why there is so much of affliction in the heart? Because maybe if the patient is in the acute state, it may be the inflammation, or maybe the prothrombotic state, which leads to MI-like affliction, or maybe because of the lung involvement, there is low supply of oxygen, hypoxia and hypotension, or maybe very high demand because of fever and tachycardia. And in a patient who is having pre-existing coronary artery disease, this increases the chance of ischemia, and ultimately it leads to myocardial injury with troponin release. So does it mean that we have to ask for cardiac MRI to each and every patient who is coming to our pre-anesthetic clinic? No. So who are the candidates where we will start asking for cardiac MRI? These are the patients who are having ongoing chest pain with no other identifiable causes, patients who are having strict changes in the ECG, or patients who are having inflammatory markers like troponin or BNP elevated, or C-reactive protein IL-6 elevated, or if they're having pre-existing cardiac disease with echo findings already there reported before COVID affliction, and patients who are having left LV dysfunction, which has been reported in the echo. Now, these are the common protocols, okay, which are usually done: CINI SSFP, then T1 weighted images, ACV, LGE, that is late gadolinium enhancement, T2 mapping, and perfusion studies. All these, and cardiac MRI is a dynamic measurement, okay. Now, coming to the neuropsychiatric complications, now the patients may have varied complications in the post-surgical phase, post-COVID phase, like fatigue and headache, dysautonomia, all these things. But what is most important for anesthetists is PTSD, that is post-traumatic stress disorder. So if any patient is having such complications or such symptoms, it is very important that we ask or we send them for psychiatric evaluation during our checkup. Now, coming to the renal complications. Now, the renal complications associated with COVID is something called COVAN, that is COVID-19 associated nephropathy. And we all know there is definitely COVID associated nephropathy, but the good thing about it is the majority of patients completely recover. There is complete resolution of AKI, but still there may be some patients who have got a reduced EGFR. So whenever any patient is coming, they're definitely going to ask for RFT, and it is better if we calculate the creatinine clearance also, so that we can tune down or we can fine tune our drugs. So what is the main reason for the renal affliction? It can be the direct viral effects, or it can be the fluid management, which has been a little bit improper, or the nephrotoxins, or something like fever or sepsis or hypovolemia, acute tubular injury. So all these things ultimately leads to a prolonged kidney disorder in COVID-19 patients. So these guidelines, it is better if we just at least once go through these guidelines, where a lot of permutation combinations of kidney patients who are having renal affliction and diabetes, patients who are having hepatitis and CKD, like that, so many combinations have been given. And these KDIGO guidelines, they're mainly published to improve the global outcomes. So we really know in such condition what sort of precaution we should take when we are managing such a patient. And definitely when such patient comes to us for surgery, these whatever knowledge we gain from these it definitely is going to come handy. Now, coming to the endocrine, everybody knows that COVID is going to worsen diabetes, or maybe patients who were not diabetic now starts showing very high sugar values. And there is definitely increased predisposition to diabetic ketoacidosis, and it persists even after infection. And more information about this can be obtained in COVID registry. But what is something which is new and very interesting is that post-COVID, many patients become thyroid positive for hyperthyroidism, or T3, T4 levels start rising. And many patients are seen to have subacute thyroiditis. It may be Hashimoto's type, or it may be even Graves' disease, where there is some amount of latent thyroid autoimmunity which is working. So, your gut feeling should say that in this patient, I have to go ahead and, do a T3, T4 TSH, okay, right? Maybe the patient is having palpitation or tremor or anxiety, which may be something like PTSD, but we have to think at the back of our mind that it can be a thyroid dysfunction also. Right, it's quite tricky. Yeah. So coming to the GI, a patient who's in the acute phase, he will have elevated liver enzymes, PTA-PT derangement may be there, low albumin may be there, but as the disease and as the patient gets healed, naturally all these things become normal. And it has been told that these patients do have prolonged viral shedding, and it completely alters the gut microbiome. Now, how it is going to reflect, or is it going to increase the opportunistic organisms and lead to sepsis, where all these organisms from the gut start entering the bloodstream? Only only research will say, and we are awaiting, and the whole world is looking forward to it, and we are waiting for some results, okay, where there will be some positive or negative correlation will be found. Coming to Messi, as you all know, Messi is something which is seen in children. We are all scared, in the third phase, what is going to happen. It's the Messi, which we all are prepared to tackle now. So what these patients have? They have fever, abdominal pain, vomiting, diarrhea and all. Such patients usually don't come to us for any routine procedures. Maybe if they have some accident or trauma, maybe we'll land up seeing one or two, but it's going to be rare. Whatever it is usually a mild disease, but some patients definitely do have hypertension and cardiovascular compromise, and more importantly, neurological compromise. Now, the cardiovascular compromise is something which is called as a Kawasaki disease, where the patients will have arrhythmia, vasopressor support may be needed, ECG may show some changes, echo may show, EF less than 55%, pericarditis, all these things will be there, and cardiomarkers like troponin B or natriuretic peptide will be on the higher side. Right. So these are the cardiac MRI findings of Messi, where they have found diffuse myocardial edema, but no LG. That means there is no myocardial injury. Right. And more common in Messi is the neurological complications, where the patient may have headache, altered mental status, cranial nerve palsy, or seizure, or reduced muscle weakness. Okay. So why we have to know this is because some of these patients may land up, to us, where they will ask to give sedation for MRI. So you have to definitely ask for the COVID status, and it may be Messi, isn't it? The patient may be evaluated for seizure or something like muscle weakness or cranial nerve palsy, and we have to think that it may be Messi, right? Now, coming to this study, which is being done in a cohort of 19,000 pediatric patients who are undergoing surgery, and it has been found that around 0.85% of them only were positive for COVID-19. That means the incidence of COVID positivity is very, very less in children. Just the same way, this is another cohort which has come from France, and here they have found 1.4% of patients, the pediatric patients, have tested positive. Now, what does it mean? Are we going to test RT-PCR for every child who's coming for surgery to us? The answer is yes. Why? Because they may be still infective, isn't it? Although the percentage is very less, we may land up getting that, that patient who's coming in that 1.4% group. So he's going to be infective, and we have to use PPE, and we have to protect ourselves and other healthcare professionals. So I think it is better if you do RT-PCR in children also, knowingly that the positivity rate is very less. Now, these are the studies which are going on all over the world. This has been taken from covid.gov.in, where we are, where the answers are not yet clear, like what are the long-term sequelae of COVID-19, or something like how less will be the functional exercise capacity of the patient, or something like is platelet or aspirin having a role in managing in thromboprophylaxis of patients with COVID-19. So all these studies are going on, right? So there may be many new informations which are coming up, which may totally change our anesthesia practice. Now, coming to the last part, so do we need a consultation which is face-to-face, or we're going to go ahead with virtual thing, right? So if it is face-to-face, it is important that at least level 2 PPE has to be there, where we are going to have goggles and N95 mask and something like water-resistant gown and all these things, right? So this is one US-based company where they are using something called Body Care platform. And here you can see for surgeries, they definitely used it, right? And they say it has got a lot of benefits. But as far as anesthetist is concerned, our main question is airway, isn't it? Okay, so how accurate will be the airway assessment if we are going ahead with virtual pre-anesthetic assessment? And are we going to, or will we be able to predict difficult airway clearly when we are doing video consultation, or on the basis of some questionnaire consultation, right? So I think I will vote for the real not online virtual consultation Fine. So with this, I'm ending today's topic. I hope you got some information, new information about the pre-anesthetic assessment of patients. Thank you very much.